Hey everyone, and welcome back to another masterclass for Decode Healthcare with Harshal. Today, we're tackling a topic that honestly strikes fear into the hearts of medical coders and providers everywhere: consultations. Specifically, we're zeroing in on office and inpatient consultation codes, CPT 99242 through 99255. Mastering these strict criteria, well, it's not just about getting paid correctly, though that's obviously huge. It's really about bulletproofing your practice and saving yourselves from potentially devastating audits. We're going to decode the notoriously strict rules, those massive 2023 guideline shifts, and the payer-specific landmines that catch so many practices completely off guard. So grab your notebooks because we are getting right into this explainer. Okay, so here's our roadmap for today to keep you perfectly compliant. We'll start by defining what a consultation actually is, then we'll hit the 3 R's of documentation. After that, we'll look at the 2023 guideline updates, jump into code selection and time thresholds, and finally wrap up with Medicare rules, modifiers, and those dreaded audit red flags. All right, let's dive right into Section 1. What exactly is a consultation? So the AMA defines a CPT consultation as an evaluation and management, or EM service, that's provided at the request of another physician, a qualified healthcare professional, or another appropriate source, specifically to recommend care for a specific condition. Now, I really want to emphasize that absolute crucial keyword here: request, right? Someone else must be formally asking for your expert opinion. You're the advisor here. You evaluate the patient, render your expert opinion, and then, this is key, you communicate that opinion back to the person who asked for it. Now, you have to be super careful not to mix up a true consult with what we call a transfer of care or a patient-initiated visit. Honestly, this is where so many practices make their first massive mistake. Say another doctor sends a patient your way and says, "Hey, please take over the management of this patient's diabetes." Well, that's a transfer of care. They aren't asking for your advice so they can manage it. They're completely handing the patient off to you. You'd build out with routine, new, or established patient E&M codes, absolutely not consultation codes. And similarly, if a patient just independently seeks you out for a second opinion, no professional request involved, that's patient-initiated. Again, routine, outpatient, or home E&M codes for that one. Moving on to Section 2, let's talk about the absolute bedrock of compliance here, the 3 R's of documentation. This right here is the most critical compliance anchor of this entire explainer. Auditors are aggressively looking for 3 mandatory milestones in every single chart: the request, the reason or review, and the report. These aren't just polite suggestions, guys. They are absolute non-negotiable requirements. If you miss even one of these, it completely invalidates the consultation, period. Let's break down exactly what needs to be in that medical record. First up, the request. You've got to have a documented verbal or written request from the requesting practitioner clearly stated right there in the patient's record. Second, the reason and review. The record has to explicitly show the clinical rationale, like why was your expert opinion needed in the first place? And it needs to show a review of the patient's relevant medical records or orders for additional tests. And third, and I cannot stress this enough, the report. As the consultant, you must create a distinct written report detailing your findings and management recommendations. And this report absolutely must be communicated and sent back to the requesting provider. If you just keep your notes in a silo and never send that report back, you failed the 3 R's test. It's that simple. All right, Section 3. Let's shift our focus to the massive 2023 CPT deletions and guideline updates. If you've been in the game a while, you probably remember the absolute headache of bullet counting history and exam elements just to justify a consultation level pre-2023. It was tedious, right? Super administrative. Well, thankfully, under the 2023 updates, that whole system is gone. While you still need a medically appropriate history and exam for clinical reasons, code selection is now completely aligned across EM categories based strictly on 2 clear pathways: medical decision-making, or MDM, or total time spent on the date of the encounter. It's a real game changer that lets you focus on actual patient care. As part of this big simplification, the AMA just went ahead and deleted the lowest level codes entirely. CPT 99241, which used to be the lowest level outpatient consult, and CPT 99251, the lowest level inpatient consult. Poof, completely gone. So you've got to make sure your coders and providers know that 99242 for outpatient and 99252 for inpatient are the brand new starting lines. Which brings us right into Section 4, code selection and time thresholds. Now, what's really interesting here is how we map the exact MDM levels and time thresholds to these remaining codes. For office and outpatient consultations, the complexity maps directly to specific time minimums. CPT 99242 requires straightforward MDM or meeting a total time threshold of 20 minutes. Moving up a level, 99243 is low MDM, or 30 minutes. Stepping into higher complexity, CPT 99244 needs moderate MDM, or 40 minutes. And finally, the highest level, the big one, 99245, is reserved for high MDM, or 55 minutes of total time. Just remember, you only choose one basis per encounter, either that MDM level or the total time spent, not both. So let's see how this builds for the inpatient and observation side with codes 99252 through 99255. Because inpatient care is, inherently a lot more intensive, the time thresholds jump up significantly. CPT 99252 requires straightforward MDM, or 35 minutes. Stepping up, 99253 is low MDM, or 45 minutes. Then we make a pretty big jump to CPT 99254, needing moderate MDM, or 60 minutes. And for your most complex, high-acuity cases, the highest level, 99255, demands high MDM, or a full 80 minutes. But wait, here is the absolute crucial point for inpatient billing: the single consultation rule. You only get to use one inpatient consultation code. That's from 99252 to 99255 per consultant per admission. That's it. Even if you see the patient like 4 times during that hospital stay to provide follow-up advice on that exact same condition, no way can you bill another consult code. All those subsequent visits during that admission, they have to be mapped to the subsequent hospital care codes, 99231 through 99233. Okay, let's dive into our final segment, Section 5, Medicare Rules, Modifiers, and Audit Red Flags. This is where we put up the compliance guardrails, because this right here is where practices literally lose money and face massive audit risks. Here's the stark reality. Commercial payers will generally accept and pay for CPT consultation codes 99242 through 99255, no problem. But CMS, Medicare, they have a super strict statutory non-coverage policy for these consult codes. They actually stopped recognizing them for payment well over a decade ago. If you try to bill a 99244 or a 99254 to traditional Medicare, it's going to be automatically denied. You simply cannot use consultation codes for Medicare patients, full stop. So you might be wondering, how do we actually get paid for consulting on a Medicare patient then? Well, you have to use the Medicare crosswalk rule. When your provider acts as a consultant for a Medicare patient in the hospital, you actually report the initial hospital care codes. That's 99221 through 99223 instead of the inpatient consult codes. And if that consultation happens in the clinic, you crosswalk to the standard new or established office/outpatient EM codes, 99202 through 99215. You're doing the exact same level of consultative work and documentation, but you're billing it under standard EM codes to make sure you get a clean claim. I also just want to briefly touch on Modifier 32. You'll append Modifier 32 to your consultation code only when the service is strictly mandated. We're not talking about a doctor just casually asking for your opinion here. This is for when a third-party payer, an insurance company, or a regulatory body legally requires the consultation. Like, say, an insurance company mandating a second opinion before they'll even think about approving a major surgery. To wrap all these guidelines up, let's quickly summarize the top audit red flags. Treat these as absolute, hard-hitting rules. Number 1, a missing written report sent back to the requesting provider. If an auditor looks at the requester's chart and doesn't see your report sitting right there, they take the money back. Number 2, billing patient-initiated visits as consultations. Remember, no formal request from another professional means it's not a consult. And number 3, accidentally reporting 99242 through 99255 on traditional Medicare claims, completely ignoring that crosswalk rule we just talked about. These are guaranteed to trigger instant denials and put a giant red flag on your practice. Which brings us to the ultimate question you really need to ask yourself today. Are your provider's charts truly bulletproofed with those 3 R's before you drop that consultation code? Go back and spot check a few records this week. Ensure the request, the reason, and the report are undeniably clear. Master these codes, implement those time thresholds correctly, and always remember the Medicare crosswalk. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.